Good afternoon and welcome to UnitedTV and welcome to Bariatric Friday in our new setting. So today we are going to discuss the eating disorder and the understanding the connection before and after bariatric surgery. Morbid obesity is often viewed simply as a problem of excess weight, but many patients, the relationship with food is more complex. Eating disorder can occur across the entire weight spectrum, including the individuals living with severe obesity. In fact, some of the most common eating disorders seen in bariatric programs involve behavior that may contribute to weight gain, while others can emerge and reemerge after surgery. Understanding these conditions is critical because bariatric surgery changes the anatomy of the digestive system, but it does not automatically change the psychological relationship a person has with food and body image and the stress and coping mechanism. So Dr. Irgau is going to join us today and answer our questions regarding eating disorder. And I can hear some of you just thinking as, well, if someone has morbid obesity, isn't that eating disorder anyway? And it's not. So that's why you need to watch this. So, Dr. Irgau, welcome to the new studio setting. How are you doing? Are you comfortable?
I am super excited. This is such a wonderful setting. I have to really congratulate you and the UnitedTV team for this fantastic job. Good job, guys.
Thank you, Ethan, Phil, Zal, and all of you did a lot of hard work for this. So now, this is one of those issues when we say eating disorder, hey, that's the morbidly obese patient. Well, we know that it's not. So why is it important to discuss eating disorder when talking about morbid obesity?
So it is important, particularly for us involved in weight management and treatment of morbid obesity, because eating disorders can be found among patients that are morbidly obese. And when we are trying to address morbid obesity as a disease and provide treatment recommendations, we have to be able to make sure that there are not eating disorders, or to what extent eating disorders are present. Because if we don't recognize them, then readiness for surgery and also outcome of surgery can be affected by the presence of eating disorders. If we have untreated eating disorders, there is a higher risk of malnutrition, weight regain, mental health complications, and there may be poor follow-up compliance. So treating obesity without addressing eating disorders can lead to incomplete success or no success at all in some cases.
So what exactly is morbid obesity and how does it differ from an eating disorder in that case?
Well, morbid obesity describes a excess fat body composition, right? And the health risks associated with it. That is what morbid obesity is. Eating disorder describes more behavior, thoughts, and psychological distress. The two can overlap. They can be present at the same time, but they are two distinct diagnoses. It's important to understand the distinction because understanding the differences will lead you to make the correct treatment strategies.
And there's also binge eating disorder, and this is something that's common overall, but it's even more common among bariatric patients. What is binge eating disorder?
So binge eating disorder often develops as a response to stress, to trauma, dieting, and emotional distress. Many patients describe this urge to continue to eat without really having control in the amount they're eating, even though they want to stop eating. Right? So an urge to really continue eating and losing control of that. Of course, it contributes to obesity, it contributes to weight cycling as well. Surgery can help, obviously, by making the portions smaller, because that's what we do with the surgery, but does not automatically eliminate the behaviors that lead to that urge. And of course, if we don't address them, then as I said at the beginning, complications after surgery can be much higher.
So this probably, patient who may not, we may not, if it's not addressed ahead of time, some of those patients may have a lot more difficulties, and also like it can maybe lead to an emergency situation. So how do bariatric teams evaluate patients for binge eating disorder before surgery?
Absolutely. So providers obviously have to look for, behaviors that look like loss of control in eating, emotional eating patterns, if there is a history of dieting and weight cycling, food obsession, secretive eating behaviors. These are all not necessarily evidence of binge eating disorder, but obviously they could be signs that would lead us to make more of an assessment. That is actually one of the main reasons, obviously, that we have a psychological evaluation of all of our patients, because this signs could be missed, particularly if the patients are not open about, telling us about these issues.
So, and some patients will not tell us.
Absolutely, absolutely. But also the important thing I should mention here, the goal of looking for these behaviors is not necessarily to exclude patients. Some people have this mistaken idea. You and I have come across even some nutritionists at some point who would say, oh, this patient has an, eating disorder. They cannot have bariatric surgery. That should not be the attitude. The attitude should be, they have morbid obesity, it needs treatment. That's a disease, right? If they have an eating disorder, we need to recognize it and provide appropriate support and treatment. So we're not trying to exclude patients. We're trying to identify the problem and provide support to whoever needs, so they are better prepared for success after bariatric surgery.
So, like, can we say that bariatric surgery cure binge eating disorder?
No, it can't, of course. Bariatric surgery can change the anatomy. It will change the anatomy, right, to make the stomach smaller, but it's not going to surgically remove the actual behavior. So surgery is changing the anatomy. It's not really curing the psychological drivers. So even though you've made the stomach smaller, a patient who has not had the behavior addressed can transition into behaviors that may mimic what happens with binge eating behavior, like grazing, emotional eating, frequent
No,
snacking.
can you give me can you give me some practical examples of binge eating?
So essentially, with binge eating disorder, patients will tell you that they feel full. They want to stop eating, but they're compelled to continue to eat, even to an extent where they may be even sick. So it's really excessive consumption of food without the ability to say, I've had enough, and push that plate away, essentially.
So, how is it different than overeating?
So overeating may be something that, people
No, I
can
mean,
do
why did this
occasionally.
one get a fancy name, and then overeating just stays as overeating?
Well, so overeating describes a situation where a person may indulge in that in certain situations, right? It's a holiday, you're on vacation, that could
So
be.
this is constant.
This is something that is happening day in and day out, essentially. So, or even if it's not happening every day, it's happening very, very frequently.
So, and I mean, this is not just for patients with bariatric surgery or bariatric program. This is maybe they have the problem and they don't necessarily see the impact, the side effects yet, but they may have it anyway.
Absolutely, absolutely. The reason it becomes obviously an issue for us, is because that behavior can lead to obesity as well. Now, we have to treat obesity, but you have to really be able to identify the presence of that behavior so you can provide appropriate support. And the treatment is mental health support, essentially.
So another eating disorder is bulimia nervosa. And what is bulimia
So
nervosa, and
bulimia, yeah.
why is it like concerning for our patients?
So essentially, this is binge eating with compensatory behavior. So patients essentially will eat excessively without control, right? But then they will elicit purge vomiting, for instance. They may do excessive exercise to try to get rid of what they've eaten, or they may abuse laxatives. So it's really excessive eating followed by behaviors to try to get rid of that, right? And this is obviously especially concerning for bariatric surgery, because not only you have somebody who will try to eat too much on a very small stomach, that by itself is dangerous, but now they are trying to cause, intentional purging, which can lead to nutritional deficiencies, vitamin deficiencies, malnutrition, electrolyte imbalance, dehydration, and not to mention the fact that the esophagus, the food pipe, could be damaged or even ruptured.
Right, because
with
that's not a natural.
Absolutely. Or the small stomach, or the connection between the stomach and the intestine can be damaged if the person is inducing violent, purging after eating.
And like Princess Diana had this, and she was suffering from bulimia, and there are a lot of Hollywood people have the same problem, and it's all about the image that they are trying to get, and then this double zero size is one of the issues, that they look extremely skinny, and then it's like, if you think about it, it's just really, like, it's really gross.
It
Like,
is.
you are on a date with a beautiful woman, and she finishes, you are at a restaurant, and then goes into the bathroom, just throws up.
Yeah, it is.
So it's not a,
It's a major problem.
yeah, I just threw up a little bit in my mouth, so now, okay, now, now this is difficult to identify in the patients with obesity. Why would that be more difficult?
Well, because obviously weight alone cannot diagnose an eating disorder, right? Many patients with bulimia may appear overweight or obese despite this compensatory behavior. Often there is shame also, right, with that behavior that pushes them to hide this behavior, and they may not be upfront with it. And proper screening requires,
So
a
one
lot
thing,
of work, right?
yeah,
Open
well,
conversations and trust.
this is important because, when we have our Friday meetings, usually we have meal.
Yeah.
So, if if I run to the bathroom after dinner, I'm always worried that you would think that I have some. Like, this is kind of like one of those issues. So, but you wouldn't think that, um, if someone, like, you would be more suspicious if someone is skinny versus someone is not. So that's why you were not thinking that I would have.
No. Yeah,
So,
but again, weight alone, weight alone would not be the reason for that. But it is really an issue. It is really an emotional problem, right?
right.
Yeah, and
I mean, that also, like, this, that, I mean, I remember maybe 7, 8 times in my life that I threw up, and it's that feeling of it is just
absolutely, yeah.
so nasty. And if you are doing it because of the psychological issues, and you do it every day, it's
Right.
just so bad.
Right, but I mean, it is important to understand that because it's a mental health problem, patients are not happy with that. So it's not a happy person who's doing that. They are also suffering with that, right? So
But that becomes like the issue of, are they being honest with their physicians, clinicians, and upfront about what they're going through? Because sometimes our patients, like,
but the barrier with this is shame, right? Because that's what it is. Not necessarily that they don't want to be transparent, but it's shame, right? So that is why it's so important that as healthcare providers, we have to be very welcoming. We shouldn't never be judgmental in our view
but
of
we
our
never are.
patients. We never are. So, and that opens up that transparency, that trust. That's why very often the relationship between a physician and a patient is unique, because you're making the patient so comfortable that conversation that they would find very ashamed of in other setting, they would open up and discuss with their physicians. And it's even more important in the setting of treatment of obesity for physicians to be very, very welcoming and open, so that patients could trust and bring about problems that objectively would need treatment.
So, Dr. Irgau, we are saying that someone who have morbid obesity doesn't have to have eating disorder, but in some cases, can eating disorder develop after bariatric surgery?
Of course, this can happen without any question. Potential postoperative issues can occur afterwards. People may have excessive food restriction. They may have obsessive calorie counting, fear of eating. That's another issue that can arise. Grazing, transfer of addiction, body image issues, all those can occur after bariatric surgery. So that's why the monitoring should not be just before surgery to screen patients, but there should be ongoing monitoring as well, particularly when patients are faced with trauma, stress, and other challenges that may lead them to such behaviors.
And I think it's all sometimes comes down to this physical image and expectation, and society puts on us, or sometimes the families, relatives, so co-workers. So
Absolutely.
and that is the reason for the psychological trigger,
Evaluation.
and that's a problem. Now, if we look at the warning signs of eating disorder, and when they should be getting professional help, what would you say for that?
So essentially, if we see that there are issues, with food obsession, there are issues with secretive eating, there are issues with, repeated vomiting, all these issues should trigger. Obviously, you have to make sure that there are no other, physical problems going on, but also you have to really question, and you have to be fairly extensive and exhaustive in your evaluation. Patients who are not following up, for instance, for a long period of time, and although there are many reasons for not follow up, perhaps an eating disorder could be a reason for a patient not following up as well. So all these are important factors that you have to take into consideration.
So, what does successful bariatric treatment look like when eating disorders are involved?
Well, essentially, you are not just treating a number on the scale, right? You want to treat the whole person. So the success of bariatric surgery is the one that addresses not only physical health, mental health, but also eating behavior. All those have to be treated, in conjunction, and that will lead to a successful outcome. If you're just focused on the scale, on the number, without really addressing other issues that could be straining the emotional well-being of the patient, then that success is definitely incomplete.
So, it all comes down to looking for proper help in the right time. Timing is
Absolutely.
important, because something that can be diagnosed early on can be treated with simple treatment plan. It may become more severe if we are not taking this seriously. So, and I know there's a lot of misperception of eating disorder and morbid obesity. People think that every person who has morbid obesity has eating disorder, which is what we are trying to, explain. This is not the case. How many people, how many young teenagers are suffering from bulimia? So their BMI 17, 16, 18, less than that in many cases. So this is a serious issue, and then looking for a timely help is important.
Yes, the important message that we are obviously carrying here, Kemal, is that morbid obesity can coexist with eating disorder, right? They can happen at the same time, but they are two distinct issues, right? You cannot look at morbid obesity and say, okay, if I just address the eating disorder, I will be able to cure morbid obesity. You cannot say it. Vice versa, you cannot say, if I address morbid obesity with a surgical procedure, I will be able to take care of the eating disorder as well. It is important, just like in any other setting, right? Where you could have two disease processes that may be related somehow. You could have high blood pressure and kidney disease, right? You don't just focus on one of them.
Right.
You focus on both of them and you treat them. There may be related and there may be an overlap between the two, but they are still two distinct diagnoses. In fact, when the problem becomes major, High blood pressure is treated by one specialist and kidney disease is treated by another.
Right.
In the same way here as well, yes, these two problems can coexist, but you cannot just focus on one of them. You have to be able to treat morbid obesity and provide the treatment. Just because a person has an eating disorder, you cannot ignore the morbid obesity, right? But you provide support and you provide treatment for the eating disorder with the appropriate specialists, and you deal with morbid obesity as well. So this takes me back to a very sad conversation I had over 25 years ago with a medical director of an insurance company. Okay, I was trying to get authorization. I was trying to get authorization for gastric bypass for a patient who weighed over 450 pounds, relatively young person whose life was just miserable because of their weight, but also they were developing medical problems. It was denied. So I was on the phone with this person, a medical doctor, and I was saying this patient needs a very effective treatment. Otherwise, they may not live for more than another 5 to 10 years. And that person on the other phone said, they have an eating disorder. Obesity is an eating disorder. You don't fix it with surgery. And she hung up on the phone at that time.
Unbelievable.
And I have to say, I have to clarify, this happened 25 years ago. Things have changed dramatically since then.
But don't we have like similar cases in some instance where we have a patient who's in the program and get a denial because they gain 10 pounds?
Sure. But we're in a different world now. We're not getting the stigmatization.
But no, I was just going after
the
medical director of the insurance company. Let's just go after that.
So the key though is that, and this is the importance of the show today, Kemal, is that what we are saying is that these are two distinct problems. They can overlap, they can coexist, they can happen in commonality, but you address them appropriately, right? Yes, absolutely. You should not just focus on bariatric surgery when eating disorder is present, but you shouldn't deny bariatric surgery because an eating disorder is present either. You have to be able to address both. Patients come to us for expertise, for support, right? They don't know all these intricacies, right? And the fact that they have a mental health problem, a psychological problem, should not be a reason for them to be denied support and a way out from that situation. It's very, very important.
Well, but this is why we have a multidisciplinary approach to this. So it's not like someone comes in and then we just decide to do the surgery and then next morning they go to the OR. So it takes 2 months, 8 to 10 weeks to get someone ready with the psych clearances and bariatrician, cardiology, in some cases pulmonary. But I think this is kind of like, it makes a lot of sense maybe for us right now, but I hope that people who are listening to us are able to kind of see the issue here. So we have, like, I'm going to add something to the example that you give with the hypertension, diabetes, and kidney failure. If they have diabetes and hypertension and they have BMI of 42, you can't just not address the morbid obesity.
Yes, absolutely.
So,
absolutely.
And then same thing in the example of the eating disorder with morbid obesity, one can be treated with maybe surgery with medications, but the other one really needs to be seen by psych and then follow up by psych.
Absolutely.
So
absolutely.
Those are all important and, good ways to explain certain issues that we hear from other people. Again, sometimes we are subject to this, just like, I never want to go to the bathroom right after I eat because I know other people are going to think that, oh, this is why he's still, Anyway, now it's summer, 90 plus degrees, and what we need is rated with Dr. Irgau. And for the summertime, we have the Indian cuisine options. So I don't know what we were thinking in the summertime, but Indian food is good. You just need to prep ahead of time.
I just need to bring it up, yeah.
Yep. So you need to make sure that you are off next day after you have Indian food. So
Absolutely.
Ethan, are we ready?
All good to go. Yeah.
Okay, so these are all easy ones. Tandoori chicken.
Excellent. So again, we're doing rating from 1 to 10, right, of our
Right.
foods, and then also explaining
Oh, these
their...
are so popular now, so everyone knows.
Okay, excellent. Absolutely. So tandoori chicken, this is actually 10 out of 10.
Oh, okay.
It's chicken marinated in yogurt and spices, and then it's roasted in the tandoori oven. High protein, low carbohydrate, minimally processed, and packed with flavor. I think it's an excellent choice for our bariatric patients, one of the healthiest choices in Indian cooking.
Really?
Yep.
So
I actually love it.
So I think you are being biased a little bit. So chicken tikka.
So this also 10 out of 10.
Oh, come on, Dr. Galik.
It's boneless chicken pieces marinated in yogurt and spices and then grilled. Lean protein with very little carbohydrate. Again, ideal for our
Well,
bariatric
since there's
patients.
chicken in it, are these like Pakistani food as well? Just because a lot of Indians don't eat.
I am not certain.
I'm just being bad. Sorry. So,
I am not certain.
all right. Well, the famous chicken tikka masala.
I would say 7 out of 10. And it's grilled chicken served in a creamy tomato-based curry sauce. Good protein, but the sauce contains cream, butter, and oil. So it's a good option, but our patients, particularly for bariatric, should focus on the chicken, on the protein, and less on the sauce because of the heavy cream presence.
Spices and all that. So, dal.
This is 8 out of 10. It's a lentil curry. Cooked lentils seasoned with Indian spices. It's rich in fiber, protein, folate, and minerals as well. It's a very good choice. It has a soft texture and filling, but in moderate portions.
And palak paneer.
Palak paneer, 8 out of 10. It's essentially spinach cooked with cubes of paneer cheese. Combines vegetables, protein, calcium, and iron. It's a good choice. Watch for portion size due to the fat content from the paneer cheese.
So now let me guess. The next one, the one that I like, is going to get the lowest rating. Samosa.
I'll give you 2 out of 10.
So good.
It's essentially fried pastry filled with potatoes, peas, and spices. It's high in refined carbohydrates and fat, low in protein. Poor choice for our bariatric patients. Sorry.
So another poor one coming, none.
3 out of 10. Soft leavened flatbread, traditionally baked in a
It's just
tandoor
like you
oven.
don't realize how much you eat when you are eating that. It's
a lot.
so good.
It's very good. I agree. It's primarily refined carbohydrates with little protein. It's definitely a poor choice for our bariatric patients.
And it's not gluten-free.
It's not.
Biryani.
Biryani, 6 out of 10. It's spiced rice dish prepared with meat, vegetables, and or broth. Protein obviously is beneficial, but rice contributes to a large portion of the carbohydrate load in this meal. I would say moderate for our bariatric patients, but focus on the meat and limit the rice.
All right, and chana masala.
8 out of 10. This is essentially chickpeas cooked with tomatoes, onions, and spices. It's high in fiber, plant protein, and excellent nutritional density. It's very good for our bariatric patients. Some patients may tolerate only small portions, however.
And gulab jamun.
Gulab jamun, 1 out of 10. This is deep-fried, milk-based dough balls soaked in sugar syrup. It cannot be any worse than this. Extremely high in sugar and calorie density with little nutritional value. For our bariatric patients, definitely bad. High dumping risk, one of the least favorable Indian foods after bariatric surgery. So not good at all.
So don't eat it. So, and I think now that's the end of it.
Yes.
This was fun.
As usual.
As usual. So morbid obesity and eating disorder are often discussed separately, and in reality, they are frequently overlapped. So today we were trying to explain how they are different than just morbid obesity, how it's being treated, when it should be, when someone should be looking for medical help, and we were hoping that this would be efficiently understood by everyone, and they follow how we are actually explaining these. So it's not easy to break these down without getting into a lot of confusion, and that's why we have the area of expert and one of the best surgeons in the United States, Dr. Irgau, with me to explain all these. And we'll be back with another Bariatric Friday session. Next week we'll be here again. So until then, please stay united. Bye-bye.
Absolutely.